Okay, well, welcome everyone, and we'll turn the time over to Monica now.
All right, let me see if I can share my screen. I practiced this and did great, but let's see if it works. There we go. Is that good, Tanya?
That's great.
Okay, perfect. Okay. Well, thank you everybody for attending today. I know these are hard topics to discuss, and nobody really wants to talk about death or dying or planning funerals, but we all know that we're all going to be there at some point, that we're going to have to discuss these things and approach these hard topics. So it's good, like Tanya said, to just kind of have the education, the knowledge, have some tools in your tool belt, and then it's available when you need it. And so today I'm going to talk about hospice and what that looks like and kind of what the requirements are to get on hospice and what services are offered with the hospice programs. And then like Tanya said at the end, if you have any questions specifically about your loved one, kind of hold them to the end till we stop recording and then we can talk more specifics after Todd is done with his portion. Okay, so like Tanya said, I'm Monica Boyer. I work with MAG, and I have a special place in my heart for hospice. I was a hospice nurse. I've always worked with the seniors and the elderly, which is my love. And then I did hospice for about 5 or 6 years, and I opened my eyes to a whole different type of nursing. Usually, nursing, we're trying to save lives and we're doing everything in our power to keep people alive and thriving. And then I found out about hospice. I'm like, oh my gosh, it's such a different type of nursing. But it was very, very rewarding to be with these patients and their families as their loved one is trying to leave this world. And it's very special. So I hope to educate people about hospice because I think they hear the word hospice and it kind of gets a lot of negative connotation that I'm going to put my loved one on hospice and they're going to pass away. So we just have to change our mindsets in thinking of your loved one is passing away anyways. So the hospice services are there to support and to help. So we're going to talk a little bit about those things. Let me see. There we go. Whoops. Whoops. I'm clicking too far ahead of myself. Okay. So what is hospice? Hospice is a type of health care that is focused on comfort and quality of life for people with serious life-limiting illnesses, typically when curative treatment is no longer the goal. Instead of trying to cure the disease, hospice care prioritizes pain relief, symptom management, emotional support for the patient and the family, and dignity. And this is all happening during the final stages of life. And the main goal of hospice is to help patients live their remaining time as comfortably and as meaningfully as possible. And so it's a service offered to patients, again, when the cure is no longer possible and no longer sought. Sometimes the patient is just like, I'm tired. I don't want to go to dialysis one more time. I don't want to go to my doctor's appointments anymore. I'm tired of taking 14 pills every day. I'm just tired. And so once you determine that the patient is just done and you're done, then it's time to, then that's kind of a flag that says, okay, let's discuss hospice. And like I said earlier, quality of life becomes the focus. Um, because it's not quantity of life anymore. You know that maybe they're going to pass away in the next year. It's not about quantity now, it's about quality. And hospice focuses on symptom control, pain management, and emotional support. And patients and families' needs are considered as a whole. So the hospice team, they're not only treating the patient, they're treating the wife, the spouse, the siblings, the children, the dog. I mean, there's been many times that I'm there when somebody's passing away and I'm trying to wrangle a dog to put him in bed with a loved one so they want to because they want to be there with them when they pass. So it's a whole team and we're there to support everybody. Okay, there are different types of hospice. There's routine hospice, which is the most common, and usually this takes place in the patient's home. Depending on the medical and spiritual needs of the patient or residents, hospice providers visit and provide services to meet the individual plan of care. So this is usually in a home, um, in either the patient's own home or a family member's home, and this is just a routine hospice. Then there is inpatient hospice that this level of care can be provided in a contracted nursing home or a hospital where the patient's condition requires more significant pain control, symptom management, or new diagnostic assessment. When hospice is done in the home, you will see a nurse anywhere from 1 day a week to 7 days a week, depending on what the level of their needs are. Usually on hospice, you start slow, and then at the end of life, when their needs are more, then they increase the visits, the nurses' visits, and same with the aide. The aide can come in and do bathing. Sometimes at first they might only need, to be seen a couple times a week, and then at the end, you might need to see an aide a couple times a day to help with bathing and personal cares. So, and then if your loved one has some pretty significant symptoms that are not going to be managed at home, then that's when you want to consider being in a hospital where you're going to have 24-hour nursing care and IVs and more different types of medications and stuff like that. So you can do it in the home, you can do it in a nursing home, or you can have hospice services in the hospital. And then there's continuous hospice, which is hourly care that can be provided 8 to 24 hours a day for crisis resolution. This is when somebody's dying and they need a lot of support. Usually it can be done in their home, and symptoms can be managed just fine at home in their own bed, which is how everybody, I think, should die, is your own bed with your family surrounded you, in your own surroundings. That's just more comfortable for people. And then respite. Respite can happen. Usually if a caregiver is just burnout and they're like, I need a break, the hospice will pay for a brief episode to have respite care so that it can be provided in a nursing home, a skilled nursing facility, or a hospital, just to give the caregiver a break. Okay, so there are some admission criteria to get on hospice. Usually the patient has to have a terminal illness with a prognosis of less than 6 months if the disease runs its normal course. Sometimes that's hard to determine. I mean, like with cancer, usually they're really good at guesstimating what the prognosis is. And sometimes you don't. Sometimes if it's dementia, you don't know how long someone can last. And so this is why a doctor's going to have to recertify every 6 months. They have to just kind of do some labs and to just see how the progress is going of the illness. If the patient or representative desires palliative care over curative care. So the difference between palliative care and hospice is definitely just more symptomatic care, comfort and quality of life. Palliative is kind of a bridge between hospice and like normal routine medical care, like home health. So if you say I was just talking to somebody today, if somebody is on dialysis, that's more curative and that's more just medical care. Well, if the client is really their kidneys are just really in failure and they're just doing dialysis to just hang on, and then all of a sudden the patient says, I'm tired. I'm tired of going to dialysis. I'm tired of this. They might want to switch to palliative and maybe do a couple more treatments and then just to kind of get things set up, and then they can switch over to hospice care when they're going to be done with dialysis and they just want to be home and not have to go to doctor's appointments, not have to go to hospitals, and just to be on comfort care. So they need documented clinical progression of disease. So this is when you're going to talk to your doctor and get kind of to show the notes of like, this client has really declined. They're losing weight. They're not eating. And then there's this Karnofsky score. This is a test that they can kind of see what their level of care is, how much help they need with their activities. I'm going to skip to this next page. So this is the Karnofsky Performance Scale. So if you're someone like me that has no complaints, I can have normal activity. I can bathe myself, dress myself, feed myself. I'm going to probably have a score of 100, maybe 90 on a bad day. But you can see the scores go down. 80 is when they're having some difficulty, some symptoms. 70 is when they can still care for themselves, but they are having a hard time carrying on normal activities or work. A score of 60 is when they need occasional help, but is able to care for still their personal needs. 50 is when they're starting to get sick and they require considerable assistance and are going to a doctor frequently or going to a hospital frequently. So at that point is when you're going to want to start thinking about hospice. A score of 40 is when they require special care and assistance. A score of 30 is when they're severely disabled. Hospitalization is indicated, but death is not imminent. 20 is when the patient is very ill and urgent hospitalization or treatment is necessary. And 10 is when they're rapidly progressing through the fatal processes. And then 0 is death. So you can kind of just looking at this, maybe do a quick assessment of your loved one and kind of see where they are at. When you get about 60 that's maybe when you're going to want to start thinking about hospice and talking to your family and talking to the doctors and start the conversations because it can happen, it can change, the change can happen pretty quick. So once they start needing more help, that's when you're going to want to talk about it. Okay, so back to the criteria. You're going to need a score of less than 50, meaning that you need help in 3 to 6 of these areas: bathing, dressing, toileting, transferring, continence, and feeding. So if people can do all these things by themselves, it may be difficult, but they can do it. Maybe they're not quite ready, but it's time to maybe start talking about it. Impaired nutritional status. A lot of people at the end of life, they lose quite a bit of weight. They're just not hungry. They're not eating as well. So they tend to lose quite a bit of weight. So you want to maybe kind of track their weight loss and and if you're seeing the doctor, often they're going to be tracking this too. So if you can show that their nutritional status is impaired, they're losing weight, the doctor will usually order some labs at that point and they can see that the albumin levels are declining. That just means they're not getting adequate nutrition. Um, Okay, so that's usually the admission criteria. We have to just show a decline. Okay, we talked about that. Okay, here are some diagnoses that you can will qualify you for hospice: AIDS or HIV, cancer, any types of cancer, CHF, which is congestive heart failure, dementia, liver disease, Parkinson's, Lou Gehrig's, multiple sclerosis, pulmonary disease, which COPD, renal disease, which is kidney disease, and stroke or coma. So if you have any of those diagnoses, you would qualify for hospice. It's just knowing the time to do that. You don't want to come on too early. Actually, I don't think there's such a thing as too early. Some people, I think, wait too long to get on hospice and then they miss out on a lot of benefits. But if you have one of these diagnoses or your loved one has a diagnosis, I think it's time to talk to your doctor and say, what does our future look like? What does this look like for us as a caregiver, as a patient? What do you recommend? And have the conversations. Okay, so the hospice is there is a team of hospice members. There's doctors, nurses, social workers, counselors, and volunteers, and they all work together to support the patient and the family. And so I'm just going to I want to talk about all these team members. So the medical director is the doctor over the hospice company, and they are the ones who certify the patient to be terminally ill, and they oversee the medical plan of care. Now, can you keep your normal medical doctor? You can, but they are probably not going to manage anything. They can order hospice. They can say, yes, I think you're making the right decision. I think it's time for hospice. They can put the order in for hospice, but then it will be the hospice medical director that will oversee the care, and they will order the medications. They will order anything that is needed. And so you can still keep your doctor, but the medical director will be the one that oversees everything. The nurse is usually an RN, and they serve as the case manager of the patient's care, and they are available 24/7, which is so great, which is what I love about hospice, because a person is not going to all of a sudden have a change in their condition between 9 and 5, Monday through Friday. It's usually going to happen at 3 in the morning, 4 in the morning, on a holiday. I can't tell you how many deaths I've attended on Christmas Eve, Christmas Day. It is very typical that that's when patients decide to pass away, is during the holidays or weekends or nights. And so hospice services are available 24/7. They'll put a big phone number on your fridge to say this is the nurse's name, and you can call at 3 in the morning and say, hey, my loved one they're having ABC symptoms. What can I do? And the nurse will usually help you over the phone. And if need to, they will come to your house and help with medications, supplies, equipment, anything that you need. There is also a social worker that is involved in hospice, and they assist with referring to community resources, like maybe let's get them started on Meals on Wheels. Let's get, they just help with all sorts of resources, and they are trained in emotional support. They can come and help the family work through the grieving process and help the family kind of navigate what the dying process looks like. And they offer all sorts of great counseling. Hospice also provides spiritual care counselor, which is usually a chaplain, which is a non-denominational spiritual support person. And they usually are trained in all the different religions. And so they can help with, because a lot of times when they're dying, they really need some spiritual support. Like, what happens after I die? What does this look like? And so they can come in and kind of help provide a blessing. They can pray over you. They can, help with all the sorts of the spiritual things that go along with the dying process. The home health aide provides personal care services. They can assist with bathing, toileting, mobility, feeding, and some light housekeeping. So typically when the aide comes in, if the patient can still get up to go to the shower, they can help them with that. At the end of life, usually it's a bed bath. And when the patient can't get out of bed anymore, so the aide will be there to help with bathing. They can take out garbages, they can change sheets, they can do some just light housekeeping. So that's very, very helpful to the family, because at that point we want the family to be family and not necessarily the caregiver. So it's nice to have a great team to help with this. They have volunteers that will come in and provide friendly visits. They can run errands and companionship. And some hospice programs, some hospice companies have some great volunteers. I've seen companies that will send in somebody to do some music therapy. I've seen people that will come in, a lady that will come in with a harp and sit at the bedside and play beautiful harp music. Um, and as the client is getting close to passing away. I've seen volunteers that can come and do massage therapy, that can offer a massage to help kind of ease some of the tensions and the pain that go along with the dying process. So they have all sorts of volunteers that can help. A dietitian is available to provide nutritional counseling. A lot of times families have a hard time that the patient is not eating. And as a nurse, I try to educate. They're not hungry because they're just laying, they're not burning a lot of calories, they're laying in bed. Their job is trying to just pass away. So they're not hungry. They're not thinking of food. They're not thinking of water. But it's really hard for families to think, well, if I don't feed them or I don't give them water, they are going to die. And so we have to remind them, well, the process is already happening. Our job is to keep them comfortable. And sometimes feeding them or giving them water when they're trying to pass away is going to make them more uncomfortable. So there's a lot of education that goes along with the nutritional aspect of dying. There's bereavement counselors that can help. They can maintain contact with family. They offer support services for actually over a year after a patient's death to kind of follow up on bereavement. Um, when I did hospice, I did take care of several young people, and those were really, really hard. Young mothers that are passing away that have, little children. Those are really, really hard, and the families need a lot more support. And so bereavement counselors will follow up with families and help them with the grieving process for over a year after the death. Therapists, there's occupational therapy, physical therapy, speech therapy. They can provide services as needed. But usually at that point, they're not doing a lot of curative stuff. We're not trying to do therapy to get them up walking again because we know that they're not at that point. Sometimes it's just physical therapy for comfort, or maybe some speech therapy to help with swallowing. So those are kind of limited, but it depends on what the patient needs. Okay, so when you are transitioning or thinking about transitioning to hospice care, it is difficult and it's emotional, and how the transition is introduced can positively impact how it is received by the patient. So these are conversations that need to be had, and it can either be with a doctor or a hospice company come out and talk to you about hospice. And when you have these conversations, you're going to want to discuss them in person, in private, comfortable setting. Consider a home visit. So these are maybe if you want to talk to a doctor about hospice, you want to consider this, or a hospice company to come out and do like a referral to talk to you about what hospice looks like. And when you have these conversations, you're going to want to limit distractions, maybe turn off the TV, turn off your phone so you can really focus on the patient and their emotional needs. You want to include significant others, um, all the family. I'll give you an example. My dad, I knew he needed hospice care because I'm a hospice nurse and I could see it a mile away. The rest of the family was not quite on board to let dad go yet. My dad was taking 20 pills a day. He was giving himself insulin shots. He'd had a stroke. He couldn't bathe himself. He couldn't dress himself. He was really, really struggling. And I knew he was done. He pulled me aside and he says, Monica, I am done. I'm tired of this. So I had to talk to the rest of the family and say, you guys, let's have this conversation. And then so we all got together, had conversations. And once we all got on the same page and said, okay, Dad, we understand. We want what is best for you. And we asked him what he wanted to do. And he's like, I'm done. I don't want to fight anymore. I can't do this anymore. And he didn't want to be a burden to us. And we had this conversation. We signed my dad up for hospice and he passed away within 24 hours. And it's because we all got on the same page and we were all in agreement that he made the right choice. And I think the mind is a powerful thing. Once he decided and he knew all the kids were on board, that's when he could let go. And so it's very important to have these conversations with family members and all get on the same page and know and let the patient know that we love you, we support your decision. And even if you don't support it, you're not going to want to let the patient know that. You can bite your tongue, but it's happening anyways. So you might as well just get on board and support the process. So these are important conversations to have with family. So you want to sit during a conversation, be willing to listen, be silent if you need to, bite your tongue if you need to, and then just repeat. And this is a good time to have a hospice representative there to kind of explain what hospice is. Which this is a good one right here. I want to talk to you about where you're going with your care. What are your plans in the future? What do you how do you see your life going? Like these are conversation starters. Like, Dad, where do you see yourself in a year from now, 6 months from now, a month from now? And maybe have these conversations. Um, this is more probably for a medical standpoint, assessing what the patient and family knows about hospice. So this is something that we would want to know. What do you understand about your illness? How would you describe your medical situation? Um, you could talk to the doctor and say, if I was the wife of a patient that was really declining, but he didn't want hospice, I would maybe talk to the doctor and say, hey, let's have a sit down conversation with my husband and find out, what you think. And so the doctor could say, do you want me to tell you the full details of your condition? If there's not, was there someone else you want me to talk to? What do you see for yourself? What are you hoping for? Just good conversations to have to kind of start the ball rolling with the process. And then once they decide, yes, it's time, I'm done. I don't want to go to the hospital anymore. I don't want to call 911 if I have a heart attack at home. I just want to just be left and pass away comfortably. Then that's when you're going to want to proceed to talk about hospice or postpone until ready. If they're not ready, then you don't want to keep talking about it. Okay. Okay, so when you're discussing hospice, you want to introduce hospice as a way to help the family and patient maintain their expectations, values, and wishes. Staying independent and out of the hospital as much as possible are your main priorities. Hospice is designated to assist you in that goal. If the patient says, I want to spend as much time with family is very important to me, then when you're receiving care at home through hospice, you can provide more quality time with your family. The hospital has visiting hours. You may only be able to have 2 or 3 people in your room in the hospital, but at home, I've seen put a hospital bed in the family room. And so you have all this open seating where anybody can come, neighbors, friends, family, church members can come and visit. And so you can have as many people as you want or less. If somebody doesn't want that, if they're like, I don't want anybody to watch me die, just put me in the back room and let me go. We're going to make that happen for them. So they still have a lot of say in how they want this process to go. And when you're talking to people about hospice, you really want to ask a lot of questions and then pause and let them, and offer information. Reinforce that hospice is intended to help the patient live as well and as long as possible. And they're going to give you all sorts of education materials on that. Okay. And then there's a lot of emotions that go along with talking about hospice. So it's really important to learn how to respond to these emotions, being present, being able to help them through their emotions and processes. There's going to be a lot of crying, a lot of tears. There's going to be the anger. And so there's a lot of ways to help learn how to respond to these emotions. Okay. And then you're going to want to summarize. Whoops. Okay. And then, express optimism for quality of life. So we want to re-emphasize over and over. This is about quality of life, not quantity. How do you see your last few months, playing out? And usually they want to be comfortable. They want to be home with their family. And so you want to re-emphasize that's what hospice does. It's all about quality of life, pain relief, managing your symptoms, and being there emotionally to support the family. Okay, so a few questions. These are actually frequent questions that we get. Does Medicare cover hospice services? Yes. So everybody who has Medicare, there is a hospice benefit. And so, and if you're not on Medicare, if you're young and you don't have Medicare, a lot of times insurances have a hospice benefit. So you're going to maybe want to familiarize yourself, like what insurance you have. If you do have Medicare, then it does cover hospice. So there is no out-of-pocket expense for that. And I guess I should tell you what hospice will cover. It covers all of that team, the hospice team that comes in to help. It will cover incontinence supplies, pull-ups, briefs, gloves, wipes. It will cover equipment, like if they need a hospital bed, if they need a walker, a wheelchair, a bedside commode, a shower chair, any IV equipment, IV poles, and then it covers all the medications. And it usually will cover medications that have to do with your diagnosis. If you come on for cancer, but you also happen to have diabetes or thyroid problems, it's only going to cover the medications that are for your main diagnosis. So, and then it's going to cover anything comfort. So usually at the end of life, they can't swallow pills, and so we're doing liquid medication. So a lot of times they're using morphine or they're using Ativan for anxiety because as your body's shutting down, the patient does tend to get anxious and they hallucinate. They start to see maybe loved ones that have passed on previously. So they start talking to loved ones, which can be scary to some people and it can be comforting to some people. So it just kind of depends on what your thought processes are. And there's going to be a lot of education going on with the nursing staff and the social worker staff. They're going to do lots of education about that. So hospice will cover medications to help with anxiety, hallucinations, mostly pain, constipation, nausea. There's a lot of things that go along with the dying process. So the hospice will cover all those medications. So equipment, medications, supplies, all of that will be covered by hospice and will not be a cost to the family. And a lot of people don't know that. So they're like, well, we can't afford it, but it's taken care of. So when should hospice be introduced? If the patient's condition overall has declined and there seems to be no improvement, then hospice may be a consideration. Who is the physician in charge? We talked about that it's the medical director, but the patient's primary physician may continue to follow their patient during the hospice course. Um, and then is religion involved? We talked a little bit about that. Hospice is not driven by religion, but spiritual concerns and wishes are often associated with death and grief. So there are like I said, the chaplain that is involved to help navigate that. Does hospice mean no treatment? No. A patient can and often do receive some kinds of treatments, such as if the client requires a secondary infection, like a urinary tract infection or respiratory infection, it can be treated and considered as a comfort measure. So we're not just going to let them suffer. We're going to make sure that they're taken care of. What if the patient lives longer than 6 months on hospice? Well, then the doctor will have to do a review and to let's see, they can be on hospice indefinitely as long as they continue to meet the criteria, which is usually they're losing weight, they're falling, they're declining, and so the doctor will have to recertify every 6 months. Can hospice patient can a hospice patient with recovery signs ever return to regular treatment? And the answer is yes. If someone improves in their condition, then they can go off hospice. We don't want to sit there and go off and on and off and on because that's really hard for a patient. But if they do improve, they can go off hospice and refer back to their normal medical treatment. And then if they decline, then they can go back on hospice. Is the home the only place that hospice care can be delivered? Nope. Most hospice services are delivered in their home, but we talked about that they can be provided in a nursing home or hospital or a hospice center. When should a decision about entering hospice care be made? At any time during a life-limiting illness or a decline in a condition where the patient is no longer wanting to seek treatment, and at that time it's appropriate to discuss all a patient's care options, including hospice services. Okay, I think that is all I have. So at the end, we'll take any of your questions. So I'm going to stop sharing and we will let Todd do his presentation and then we'll revisit. Thank you.
Okay, well, thank you very much, Monica. My name is Todd Lauder, yes, with Walker Sanderson Funeral Home. I can just echo what Monica has to say there, how hospice is a great blessing for many people. I experienced that personally. Those hospice nurses are angels. It's a great service. And I'm here to talk about funeral pre-planning. And what does that mean? And how does that work? And It is something that I'm passionate about. Having gone through my boring story is I was just a simple physical therapist for 25 years, going about my life. And then I was introduced to the funeral business. I was in charge of 2 funerals in 2 months. I learned all about the funeral business the hard way. I didn't know anything about funerals. I never experienced that. But when you're in charge of a couple of them real fast, you learn a lot about funerals. I learned that I made a lot of mistakes and I learned that I spent a lot of extra money that I could have avoided if I would have known about pre-planning. I didn't even know it was a thing. So I learned that there's a pre-planning situation where you can be prepared, and it makes it a lot easier on your spouse or your children by being prepared. And so what does it mean to be prepared in a funeral? And I echo I know this is hard stuff. A lot of people just, yeah, I don't like to talk about my death, or the death of my spouse or my parents or my children. It is a tough conversation for a lot of people. But unfortunately, it is something that we all have to deal with. There is no dodging this. There's no escaping this, darn it. What is pre-planning, and how does that work? Well, basically, in a nutshell, what you can do is you can pick out whatever you want done. You can pick out cremation, you can pick out burial, you can pick out your funeral plan, you can pick out your casket, your vault. You can pick these items out so that when you pass, your spouse or your children don't have to try and make those decisions. It's already been picked out. You've already picked these things out. And you can pay for them at today's prices. That's the beauty about a pre-plan, is that you can pay for it now so that in the future, 10, 20, 30 years from now, when you pass, everything you've picked out is paid for. So your children or your spouse doesn't have to try and come up with this money at a time when they're grieving and they're mourning. They don't have to try and come up with these funds to cover your funeral or for your spouse. And so the way that works and the genius of this is that you're doing this, making these decisions now at a time when you're not emotional, you're not grieving. I'm the poster child of what happens and what can go wrong. When my wife passed away 6 years ago, what do we do when our spouse passes? It's typical. You go into the funeral home and you say, "What is the nicest casket you can find? I don't care how much it costs. I'm just writing out checks." It's just our nature to try. It's an overspending. It's the emotional overspending that's pretty common. And so, yeah, my wife would have never picked out the things that I picked out because she's much more sensible and practical. She wouldn't have been spending all the money like I did. But when you're emotional, that's what you do. So you can avoid that by pre-planning. And then the 2 months after my wife passed away, my mom passed away. And so I was in charge of another funeral. And I experienced what happens when the kids have to be making all these decisions. Me and my brothers debated over everything. Well, I was going to say we argued. Well, we didn't really fight about everything, but we debated over everything, what casket and all these kind of things. And all that can be avoided if it's like, wow, I could have brought my mom in here 20 years ago and we could have picked all this stuff out 20 years ago so that me and my brothers wouldn't have gone through all that stuff. I have one sister. Thank goodness she was kind of the tie-breaking vote for everything. But it's nice to know that the kids, because when kids have to pick out your casket and these kind of things, there's a big guilt factor. And this is where one sibling wants to spend a lot of money, one sibling doesn't want to spend any money, and you feel guilty no matter what you do. You pick out a really nice casket, you feel guilty you're putting your mom in this really expensive casket. You pick out the cheaper casket, and you feel guilty you're putting your mom in a cheap casket. You feel guilty no matter what you do. But no matter which one mom picks, she can pick out the nicest one, she can pick out the least expensive one, and the kids say, "Hey, that's what mom wants, that's what mom gets." There's no debate, there's no arguing, there's no guilt. It's just it makes it go easier and smoother when you've picked it out yourself, so the kids don't have to mess with all that. And then the other nice thing is that they don't have to pay for it either. When I found out about this pre-planning, I did some schooling, I got licensed, and now I work for a funeral home. Go figure. 10 years ago, you would have told me I was going to be not doing physical therapy and I was going to be working for a funeral home. I would have thought, oh, that's crazy. But here I am. So yeah, and I really enjoy this. I really enjoy helping people. It's a different way. Instead of helping people with a knee replacement, I'm helping them with planning for their future. Some people plan for their parents. Some people plan for themselves. Some people plan for their children. They may have a special needs child, and they're afraid that if that child outlives them, who's going to take care of their funeral? And so parents are doing that. There's a lot of flexibility. There's a lot of ways that you can help yourself and your family with these pre-planned policies. And here's the genius, though, also about the pre-planned policy. Because a lot of people say, well, yeah, I'm familiar with that. My mom had one, or my brother's parents had one, or I mean, my brother's in-laws had them, or some. So I'm familiar a little bit how it works, but I'm afraid to do that because I might be moving someday, or what happens if I change my mind? Well, these pre-planned policies, they're transferable and they're also flexible. The way it works, and this is part of the genius of it, is that you don't pay the funeral home for your products. You can pick out your funeral plan or your cremation plan and your cat. You can pick all these things out, but you don't pay the funeral home. It's illegal for a funeral home to take your money in advance for a funeral. It has to be put into a policy. It's actually a life insurance policy. It's in your name. It's an asset that you own, but it's in a contract with the funeral home. Funeral homes will have a contract that spells out everything that you wanted. All your choices are all spelled out in the contract, and then the life insurance company takes the money and holds it. And you have a policy so that when you pass, the funeral home calls up the life insurance company, and boom, in 3 days, here's the check. It pays for everything that's in your policy. No matter what inflation has done to it over the years, doesn't matter. You've already paid for it at this price. That's the beauty of it. And then by being in a life insurance policy, if something was to happen to your funeral home, if your funeral home went out of business or got hit by a tornado, you can transfer that policy to another funeral home. It's a simple one-page form, transferring from whatever funeral home you got it from to whatever funeral home you moved to, Arizona or Idaho. You've signed that form, boom, now they have your policy. So they're transferable and they're flexible because a lot of times people say, well, I think I want to be buried and I can pick out my burial plan and a casket involved and everything. But what if 20 years from now I want to be cremated? Okay, well, when you pass, your family would meet with the funeral director and they would say, oh, here's your pre-planned policy. You paid for all these things. And the family says, oh, but you know what? We talked with dad about this a couple months ago, and he decided he doesn't want to have the funeral, burial, all that. He just wants to do a simple cremation. Okay, well, that cremation plan is much cheaper than the burial plan that he paid for. That money difference is refunded to the family. It goes back to your family. It's your policy, it's your money. It's not the funeral homes or the life insurance companies, it's yours. So there's flexibility there. So you don't have to know exactly what you want. You can change your mind. But you can have it paid for and you can have it done so that everybody is not up in the air about what to do with mom or what to do with dad. It's done. So they're transferable, they're flexible. And the other nice thing about a pre-planned policy, it doesn't have to be paid for all at once, like a funeral. Funerals have to be paid for all at once, but a life insurance policy that does a pre-planned policy doesn't have to be paid for all at once because a lot of people don't have $10,000 in the bank or whatever their funeral would cost. This policy can be paid over 3 years time, a 5-year time, or a 10-year time. The life insurance companies let you have that payment plan, and you can always pay it off anytime you want. And there's the details about all that. So it's nice to know you can pay for it in advance. You can make these decisions when you're practical and when you're not emotional. And you can do it at a time ahead of time. So it's a lot easier on you. It's a lot easier on your family. And it's easier financially because the inflation is not our friend. The funerals are expensive and the price goes up every year. The cost of funerals just like everything else goes up and up and up. Plots, cemetery plots, those expenses go up every year. So it's nice to know you can pay for them in advance before inflation eats up your dollars. Oh, and then one other thing. This doesn't apply to a lot of people, but for those that it does, it's a big deal. a pre-planned policy can be made irrevocable. There's a lot of times where somebody is in an assisted living place or in a skilled nursing facility, and they need to go on Medicaid, which will pay for their facility, not Medicare, but Medicaid. And to get on Medicaid and the new choice waivers that pays for these things, you can't have more than $2,000 to your name, your assets. You have to spend down your assets down to under $2,000. A pre-planned policy does not have to be cashed in. You can keep it. We can make it irrevocable, which means it has to be used for a funeral. You can't cash it in later. It's made just for your funeral. You can make it irrevocable so that it doesn't count as an asset. You can have a 8, 10, $15,000 pre-planned policy and still qualify for Medicaid and be able to keep that policy. You don't have to cash that in, so that when you pass, your funeral is paid for. Your loved ones don't have to do that, and you can still qualify for Medicaid. So that's a nice thing that the state did right. And so that's the kind of in a nutshell, that's kind of how the pre-planned policies work. Funeral homes love pre-planned policies. They help. It just makes it go easier on the people, easier on the funeral home, easier on the family. Um, and so, of course, if this sparks any questions, that's what we'll do now. We'll turn the time over to you to ask questions, and Monica and I would be happy to answer any questions you had about any of these concepts. Thank you, Tana.